Hello and welcome to Yodo.
Hi, good afternoon. I'm Dr. Tartaglia.
Dr. Sarah Bohn.
And we're here today to talk about a topic. We want to talk about the levels of care of hospice individually. So this video is going to be about inpatient level of care for hospice patients.
Inpatient level of care is when the patient has an acute need and doesn't want to go back to the hospital. And the need is severe. So it's a symptom driven, not a diagnosis driven. Usually to get admitted to the hospital, you have to have some kind of a disease process that's abnormal. If you just go in for pain, they're likely not going to admit you. If you go in for shortness of breath, they're going to find out what the cause of shortness of breath is, treat it, and then they're going to discharge you. But an inpatient care unit is for somebody who's on hospice, so their life expectancy is limited, and they're having an acute symptom that needs to be managed, and they're having trouble managing that in the home environment. Most people want to be at home. The little girl with the red shoes was not wrong. There's no place like home.
They do want to be at home. And some of those patients get admitted directly from the hospital, meaning they were very ill in the hospital. Their prognosis is less than 6 months, and they are too unstable to return home because their symptoms were not able to be controlled in the hospital and might require a higher level of care that they do not want. Like, for example, BiPAP, or which is a mask to go on your face to help you breathe, or to be intubated, which is basically life support. So these patients have said, that's not for me, and no matter what the acute care physicians are doing, it was the symptoms were not managed well. So those patients will go to the inpatient level of care, and they are met there with the team. Just like the interdisciplinary team that comes to your home, there's a team in the hospital. And the goal of the inpatient physician is to manage those symptoms so you can return home.
Sometimes the patient wants out of the hospital. They just want out of the hospital. I've been here, I've come back, and every time I come back, I actually get a little bit worse, and they do more things to me. And I'm tired of these things being done. So the patient may be stable enough to leave the hospital, but they're not stable enough or controlled enough to be able to go home. And that's a great place to kind of go to, sort of in the in-between. It's not a nursing home, although some inpatient care units are located in nursing homes. Those patients are cared for by the hospice staff and not solely by that nursing home staff in that inpatient setting. So you have a patient who's in the hospital, they have a critical illness and a bad diagnosis, and they want to leave. They want to get out of there, but they're not ready to go home. Or maybe the people at home, there's nobody at home, and they need another place to go, maybe a nursing home. But still, the patient is not at a point where they could go to another place, and that's an ideal time to use and access the inpatient care unit.
Yes, and it is a short-term visit usually. And it's for
short-term stay.
Short-term stay, yes. And as what Dr. Bohn said, it's for symptom management. So it could be pain, shortness of breath, nausea.
We said that in unison.
Yeah.
Vomiting, even diarrhea, or maybe they've got a skin lesion that's needs some wound care, and they just need some extra help to manage whatever symptom it is for a few days, 3 days, 5 days, maybe 7 days before they go to the next location.
Yeah, agitation is another big diagnosis that we see a lot. Sometimes agitation increases when patients change level of cares, meaning they are going in the hospital, they've already have a baseline of dementia. They will get worse, and they just need to come to the inpatient unit where symptoms can be managed. In order to stay in the inpatient unit, you do have to be managing symptoms.
Once the symptom is managed, there's no reason to stay there.
Yes. So then sometimes the discharge planning can be difficult, but that's why the interdisciplinary team works with the family to meet them where they're at. As a former hospice medical director, I spent a lot of times doing chart audits to determine eligibility for the care. It's not that hospices do not want to provide the care in the inpatient. It's just, there are guidelines by Medicare, brought forth by Medicare, and you need to be documenting the changes and making changes to the regime.
There's a lot of money at stake. And so to keep hospices honest, Medicare has a pretty good idea of what percentage of patients off of a particular panel are going to need that kind of care. And if for some reason your hospice is either too low or too high, then they're worried about what's going on with this hospice, that they're not managing their patients. Either they're not identifying the patients that need to go to the hospice unit, or they're sending too many to the hospice unit. Is there a staffing issue? Are they afraid to treat those people in the community? What's happening?
Yes, and once you're in the inpatient unit, the discharge planning is not like the hospital. It's very in-depth. We change the discharge planning as the patient changes, as the disease progresses. It could happen in hours to days. And we do not work in a rash manner that, for example, Dr. Bohn wouldn't go in and round and say, 11 o'clock, you're out.
No, it doesn't work that way. We try to give the patient and the family notice on a daily basis, sometimes twice a day or even almost hourly, about what's happening, because it's very dynamic. These people are often very, very ill. And Dr. T mentioned the interdisciplinary team. So it is the physician, the nurse practitioner, the nurses on the floor, the aides that are in the building. And so there's round-the-clock care for these people. A key component for that interdisciplinary team is the social worker and the chaplain. And they usually are also available on a daily basis. The chaplain may even come in the middle of the night if the family would request that.
Yeah, most inpatient units that I've worked on, normally the normal request by Medicare is to have an interdisciplinary team meeting weekly for a routine level of care. But for inpatient unit, you generally do collaborate with the team daily. At least daily, you make touch points, because you want to make sure that everyone is understanding the disease progression. And as we physicians, we're the experts, so they're leaning on us to kind of guide them at the care.
So a little side story, it was actually an inpatient care unit that brought me to Florida. And I worked in a small community just on the other side of, kind of between Orlando and between Tampa. And that inpatient care unit was a smaller unit. It was a 12-bed unit. And you think, oh, that's not very many people. These people are critically ill.
Yeah.
And so even though it sounds like 12, that's small, it's hopping. Many inpatient units are between about 12 and 15. Some of them might be 16. But once you get much past about 16, it's more than one physician is going to be able to manage, because these people take time and the families need information. They want to know what's happening with their loved one.
Yeah, and there's a large percentage which people don't understand that come to the inpatient unit and they pass away within hours. They take a lot of resources to the team, because you're receiving the patient. Oftentimes, for myself, no matter where, even in the hospital setting, if the inpatient unit is within the hospital, I have never laid eyes on that patient until they transfer. And when they transfer acutely ill and dying, it's very difficult for the staff, for the family, for us. We have to really have quick communication and hope that the family's there. Because sometimes I've been there where a family went home to go have dinner and they do the transport late in the day, and I happen to still be there closing charts, and the patient is actively passing.
The sad thing about many inpatient units is the patients do arrive critically ill. And it was a learning curve for me to understand and realize how many patients are at the hospital at the end of life, and it is not where they want to meet the end of life. At all costs, they want to try to get to a more home-like environment. And sometimes it's just not reasonable for them to go back to that family home. They just need too many resources and too much care, and the family can be with them in that inpatient unit. The inpatient units, everyone I've worked in, has been beautiful.
Oh, yeah.
The rooms are larger. One of the units I looked at, the sliding glass door would open to the outside covered patio that was an enclosure for every single room, and you could literally push the bed, the hospital bed, out into the enclosure. We had families that would show up and camp out in the backyard, almost like, tailgating. And, depending on what the family culture is, sometimes it was almost like a party-like atmosphere with, tailgating and pitching of tents and bringing campers. And they would camp out even though it was for just a few days, maybe 3 days, 5 days, 7 days while that patient is there during either the stabilization or end of life. And that family would put together this,
Beautiful
big
celebration
of life, that they would all be together during that time period right there on site.
Yeah, and also you can bring your pets to the inpatient unit. Your children can come. It is just if your family wants people to come, there's no set visiting hours. That's what I'm trying to say.
They can come 24 hours a day and they can stay. I get to the facility early in the morning because I like to round and get there to start rounding when the evening shift or night shift is giving their report to the morning shift, so I can hear firsthand what happened during the night. And I might go into some of these rooms and I'm literally stepping over sleeping family members that are there on, cots or rollaway beds or sleeping on the floor in sleeping bags because they want to be there with their loved ones. And the nursing staff and aides just love having that patient get that kind of care and attention from their patients. It's truly beautiful.
Right, and culturally speaking, I've been in rooms with all different types of music playing. Some rooms want to be silent. Some people are burning incense. One of my most interesting cases that occurred to me kind of right out of residency, I took care of a patient that lived in a campground. And, in Florida, that's really common because people come down here for the winter and they reside in a campground. And this was a really pretty, beautiful one all the way out in Loxahatchee, Florida. But what I didn't know is the campground was clothing optional. So when I arrived, it was a little bit of a shelter shock for me. And it was one of my very first patients. And so what had happened with this gentleman is he was a younger gentleman that had a cancer diagnosis, and we were having great difficulty controlling his pain. So we were able to convince him to come inpatient. But the problem is people that are a clothing optional culture, there's certain expectations that they don't want to be told that they have to wear clothes. So what did our volunteers do? They got these huge flannel blankets, cut holes in the center of them, and all they were required to do was wear these blankets over their head. So they're covering their essentials. And I have to tell you, it was just beautiful. Everyone coming in and out. And quite honestly, it was not safe for him to return to the campground. His wife really couldn't handle his dying. So everyone moved to our unit, which was really far for them to drive. And they just took turns and shifts and sleeping, and they would bring their food, and they all had the same flannel blankets that we had our volunteers cut holes in. So they abided by the rules of the unit, because our inpatient unit also housed our executive offices. So there was a lot of people, and he was able to die the way he wanted, with dignity.
Yeah. And that's what we want to be able to do, is we want to manage the patient body, soul, spirit. We want to manage their symptoms that they're having, because we know it's a lot of heartache for everybody involved to lose a loved one and to realize that time is coming. And only 10% of us are going to have a sudden end of life. The rest of us will see that end of life coming in stages over weeks, over days, over hours, and then finally those last few minutes. So it's imperative for those last few minutes to be wonderful, to be as beautiful as we can make it, with comfort and as close to a home-like environment as we can possibly manage.
Yeah, and I just want to touch on, a lot of times people think hospice is a place, and it is an inpatient unit. And we, as hospice and palliative medicine physicians, have to spend a great deal of time educating. We will have patients that are still walking, talking, eating, and not even in the stages of dying, but they do have a terminal illness. And families sometimes will have belief system, and even the patient, take me to your unit, give me the shot. That's not what an inpatient unit is about. No. So people like that, we want to get them back home and settled, because they have to learn their new normal.
Right. And we do have successes where patients don't come to the facility and pass away.
No.
One of the patients that I cared for at the inpatient unit in Auburndale, the patient came in with extreme pain, and he was a rough, tough, tumble sort of fella in his mid-50s and was part of a motorcycle appreciation group. Yeah. And so he came in with extreme pain because of his malignancy, and we were able to do was over a few days able to manage his pain. And because it was an inpatient unit, and we want to allow for that family and those friends to come in, a lot of them did come, and they would come from maybe where they worked or maybe a recreational activity when they would come, and they would come at all times of the night and day. Now, they did not create any havoc for the nursing staff, but sometimes they could be louder than what would be expected, and their music choices might be quite loud or different than what some of the older population was comfortable with. And what we did is we had him, the family warned us that this is probably what's going to happen, so we had him down on kind of like an end hallway, and they were able to camp out and bring their motorcycles and rev their motors and play their music, and it was great. And we just, when I would go in there, they were always so respectful to me, and I would just tell them, please keep it down to a dull roar, because not everyone appreciates what you guys want to have here, because it was really almost like a party-like atmosphere for them.
That's nice. And, just to re-emphasize, there's a lot of people that just come to the inpatient unit for 24 to 48 hours for a transition to home, because the family's trying to get everything in place. We do, hospices do cover the durable medical equipment, so maybe a hospital bed has to be delivered, and it's not so much that can be done instantaneously, but does the house have room for it?
So the hospice agency will deliver that stuff, but they're not going to move your furniture. And so sometimes families have to have time to get a room cleaned up or to get furniture moved out of the way so that those deliveries can occur. So the patient could come from a hospital to the inpatient unit, or could be at home and now becomes poorly managed. Maybe end of life is nearing, or maybe the disease process has advanced, or like with congestive heart failure, there's been an exacerbation because of maybe too many Fritos and too many Lay's potato chips and
Chinese food.
They thought, they thought, oh, I got to drink 8 glasses of water a day. No, you don't. You need to talk with your doctor about how much fluid you need to be taking. But for whatever reason, the patient was at home and now has a symptom that's out of control, and they need to have that symptom acutely managed on an ongoing basis.
Right. And what they'll do is they'll come into the unit and they'll be seeing a physician daily, because sometimes in an outpatient setting, that physician is not able to go there daily, or the staffing is not equipped for it, and they will come up with a treatment plan. And once that patient is stable, then they bring the patient home on the new regime, and they're now at the new baseline, and we manage them there until there's another event.
So if a patient is at home and they become unstable, they have that option of going to an inpatient unit. We do have another video about crisis care or continuous care. Some hospices call it one thing, others call it the other term, but CC is typically what it's phrased. And if for some reason the patient either isn't eligible for CC because the symptoms are too severe, the family is not comfortable with continuous care, or the staffing is not available for continuous care, that hospice agency is going to encourage that patient to go for an inpatient unit rather than going back to the hospital one more time. And typically, that's what most patients are going to want to choose. They don't want to go back to the hospital one more time.
No, and they just want to be in a calm environment because that's what they're leaving. And then also it provides time for the family to get education. Say, for example, like Dr. Bohn talked about earlier, if you have a wound, wound care is done primarily by hospices, but sometimes if they're weeping and they're more difficult to manage, meaning that they need changing every day, we instruct the family. So it's good to come into the inpatient unit, come up with a new plan for that wound and show them. Medication management can sometimes just be from a dropper, and that's hard for people that are seniors, so we explain it and we show them. So there is an educational component to
and so they may be there
care.
just for that education. If you haven't seen the other videos on respite care, which is another level of care, that's you can find that below. We also have a video on the continuous care, and we have a video on the routine in-home care, because hospice does have 4 levels of care.
Right. So hopefully you found this video to be informative. We hope that we gave you enough information to understand what the inpatient level of care is.
It's not something to be afraid of.
No.
If your loved one needs that level of care, they're going to make it as home-like as they possibly can. You're going to have round-the-clock nurses to care for your loved one, and you're going to have access to all those interdisciplinary team members.
Yes, and sometimes I want to say you need to give yourself grace, because there are certain patients that just cannot die at home. Like Dr. Bohn said, there is no place like home, but sometimes it is just not feasible, and you need to give yourself grace, and it's okay, because your loved one will just want peace. That's what they find at home, and that's what they'll get at the inpatient unit. So thank you so much for joining us today.
If we said something that didn't sound right, or you got a question, let us know in a comment below. But we'll see you next time.
Bye now.
Bye.